Well, I just want to say good morning or good afternoon, depending on where this broadcast today finds you. Thank you for joining us for another installment of our essential substance abuse skills training. Great to see a few familiar names, and if you're brave enough to turn on your camera and comfortable with that, we'd love to see you as well. So I see Kevin's getting connected there, and we'll let everybody get settled in here virtually before we get started. Got a few others still connecting. There we go. Looks like Kevin's connected now, and looks like Lacey's still trying to get connected. So let's give her just a moment here. Well, I hope today's broadcast finds you well and safe and healthy. And we're hoping to review some important information today on ethics. The CEUs today, you would be able to apply towards your ethics certification or licensure requirements. So I know most states need at least 3. That may vary. I know Iowa, you need at least 3 every certification period. So this would qualify for a NADAC approved ethics continuing education unit. So that's good. Looks like everybody's set and connected. So let's go ahead and get started. Again, I want to welcome you to the Essential Substance Abuse Skills Training. Today's topic is professional and ethical responsibilities. And we have back our, I'm going to say you're our regular ESAS presenter now, Avis. I think you've achieved that title. But we have Avis Garcia back to review and talk about some important ethical considerations related to the helping professions, particularly the substance abuse and social work fields. For some of you, this may be review or refresher, and for others of you, it may be something that you're just getting some exposure to. So we're really happy to have you all here. I have a few introduction slides to go through, and then we'll turn the floor over to our presenter today. And we're going to try and leave a little time at the end for discussion, but I have Jeff Ledolter, a colleague of mine, on with our Native Center for Behavioral Health that will be kind of monitoring, helping me monitor the chat box. And we can try and field some questions as we go. There'll be some quiz questions at the end that we're hoping to get some interaction from all of you as we as a group sort of look at some of these ethical dilemma questions, if you will, and maybe as a group to try and come up with the best possible answer for those quiz questions. So be prepared for that, and we'll get started here. So again, I want to welcome you all and thank you for taking the time out of your schedules to be with us today. This event is brought to you by the National American Indian Alaska Native Addiction Technology Transfer Center. We are located at the University of Iowa, here at the College of Public Health on campus. We are part of a larger national HTC network made up of 10 regional centers, a national Hispanic and Latino HTC center, as well as a HTC coordinating office at the University of Missouri in Kansas City. This project is funded and supported by SAMHSA, and just to be advised, the content is developed by the presenter, and the opinions expressed do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian Alaska Native HTC. As I referenced earlier, following today's event, we will reach out to you via email and make available to you a copy of today's slides. We'll also, there'll be instructions in that follow-up email where you can request CEUs for today's webinar. And lastly, there'll be a link for a short survey The survey is important to us, so please, it allows us to continue to show our funders how we're using their resources, and it ensures that we're able to continue to provide events such as this. Of course, your participation in the survey is voluntary, but we would really appreciate you taking a few minutes to help us by completing this short survey. You can skip any questions you would like, and you don't necessarily have to complete the survey, but all your responses are kept confidential and cannot be linked to you in any way. If you have any questions about the survey, please reach out to me here at the center, and I'm happy to talk with you about that if you have any concerns. So look for that follow-up email. You can request CEUs that way and get a copy of today's presentation. I know we're gathered here virtually today, but before we begin, we wanted to take the time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Keely Driscoll, and our co-director, Mr. Sean Baer. Thank you. Well, without further ado, I want to once again, introduce my colleague and my friend, Dr. Avis Garcia. You're currently muted, but you can use the chat feature today as Dr. Garcia presents the information. If you want to put comments in the chat box, Jeff and I will try and address those as we go, or circle back to them at the end of today's presentation. But again, Dr. Avis Garcia is an enrolled member of the Northern Arapaho tribe and is affiliated with the Eastern Shoshone tribes of the Wind River Reservation in Wyoming. I know that she is currently located in Montana and is a licensed professional counselor and an addictions therapist. She also holds a doctorate in counselor education and supervision with a specialty in substance use disorder treatment and working with Native Americans. Avis has worked with a variety of populations, couples, families, youth, and she has a specialty again in the treatment of substance use disorders and trauma. Really happy to have her here. She has at least a couple of decades of experience, clinical experience to her credit. And we're really happy to have her as a member of our consultant team and advisory board. So Avis, I think I've talked enough about you. So if you want to add if you want to add a couple more things, you sure can. But
all righty.
I'm going to pull my screen down so that Avis can get her slides up, and just bear with us here while we transition. And again, it's great to see all of you, and I'll turn the floor over now to Avis. Thank you.
Okay, let me get set up. I have to go to my desk, okay, to share my screen and pull up my slides. Sorry, guys. Go from the beginning. And thank you guys for taking time out of your schedules to be here today. As Steve mentioned, I have a couple of decades of experience in the substance abuse and mental health field, mainly working with Native Americans as a Northern Arapaho and Eastern Shoshone tribal member. I'm enrolled Arapaho, but I'm also Eastern Shoshone. My father was Eastern Shoshone and my mother was Arapaho. And I am currently the Director of Clinical Services for the Crow tribe in Crow Agency. And I've been here for 7 months. Yesterday was like my 7 month marker. So I've really enjoyed being here and working with the people here. And I've been doing this series it's been a year, so I'm actually cycling through these slides again. And for me, it's always a refresher to keep this stuff ingrained in my brain, which is why I love to teach and do these webinars, because it just solidifies my knowledge in this field of the work that we do. So I hope that this is very beneficial to your work that you do, and we'll go on ahead and get started. Today we are covering ethics, professional ethics, which is a very important part of our work that we do. So the objectives for today are to cover the ethical principles, which is autonomy, non-maleficence, beneficence, social justice, fidelity, and veracity. The 13 principles of effective treatment, briefly discuss the professional code of ethics, and address ethical responsibilities, which includes our codes of ethics, patient rights, mandatory reporting, boundary issues, and use of supervision. This is blocking my view here. Okay. Vocabulary that is specific to this session is discussing morals, principles, ethical values, and scope of practice. So to begin with, principles of effective treatment is substance use disorders are a complex but treatable disease that affects brain function and behavior. No single treatment is appropriate for everyone. Everyone needs different treatment modalities. Various types of treatment needs to be readily available. Effective treatment attends to multiple needs of the individual, not just their drug use. And remaining in treatment for an adequate period of time is critical. The length of stay is important. And that is according to NIDA, the Principles of Drug Addiction Treatment. So people can and do recover from substance use disorders. That's one of the good parts of the work that we do, is getting to see people who actually make those changes. And I'm actually seeing more and more people recover to the point of having the interest to pursue education and become counselors themselves. And so that's always exciting for me. The notion of one pathway or approach to treating substance use disorders is no longer sustainable. There may be common themes or particular approaches, programs that work better for some than others, depending on a variety of factors. So we may be looking at their readiness to change, the presence of co-occurring disorders, their gender, trauma history, age, culture. And then we also look at the mental health issues, relationship issues, gambling, legal problems, child custody, parenting issues, medical issues, medication assisted treatment. Sorry, sometimes I slur my words. And then we'll go on to the next slide. More principles of effective treatment. Behavioral therapies are most commonly used forms of drug abuse treatment. Medications are an important element of treatment for many patients. The assistance of medications is widely accepted with the behavioral health field. However, not all patients will need medications to experience a meaningful recovery process. And that's usually in regards to those that are struggling with mental health issues. I see a lot of bipolar individuals, people with anxiety, people with depression, and those that have engaged in long-term methamphetamine abuse often come with psychosis that's been induced by long-term usage. An individual's treatment plan must be assessed continually and modified as necessary. Remember that that treatment plan is a living document. And so it's really important to always be monitoring them. What I like to do is give them, their treatment plan, or give them a sheet that they use each week that focuses on their treatment plan, so that they're working on those goals and they get to see that progress and put a little more effort into achieving them. And individuals with substance use disorder may, like I said, also have mental disorders. And detoxification is only the first stage of substance use disorder treatment. There are many studies that suggest that as many as 2 out of 3 have a co-occurring or comorbid disorder of some kind underlying their substance use disorder. This notion also makes sense of much broader biopsychosocial scale as well. I want you to consider broadening your definition on this idea of co-occurring disorders. Think about the human conditions such as grief and loss and trauma and chronic pain. I also want you to think of a person's substance use as a symptom or an indicator of an underlying co-occurring disorder. And what I mean by that is I often see it, their use of substances, as a coping mechanism to help them manage their self-medication of treating whatever co-occurring disorder. And I do know that almost every single person that walks in the door here looking for our help and needing our help has experienced some trauma, some of them multiple traumas. And so we always have to be mindful and, educating ourselves to using trauma-informed care services that we provide. And detoxification is only the first stage of treatment. It is a vital step in the continuum of treatment services, particularly with patients that have moderate to acute substance use disorders, or they exhibit symptoms related to withdrawal. So think of this as stabilizing not just the body, but treating the brain as an organ that is compromised. Until we treat the brain disorder and properly detox a patient, progress along with the addiction and treatment continuum will be wrought with liabilities. Treatment does not need to be voluntary to be effective. Drug use during treatment must be monitored continuously, as lapses may occur. And I often inform the patients that, don't be so hard on yourself, because I do see it. We all see it. And that some of our clients will, be really hard on themselves and feel like a failure, and just normalizing that process for them helps alleviate that guilt and shame that they must be feeling because, they had a slip and used. So it's being able to taking that relapse as a learning opportunity to help them better prepare for staying clean and sober after that. It's important. The relapse issue is important and should be handled with great care. Most treatment centers are abstinence-based, so we need to be real careful about that. And then I've often heard, well, do you use harm reduction? It often depends on the individual and what circumstances bring them to the program. And for some, that might work. And like I said, everybody is different. So what's good for one person doesn't mean that we do all the same. But our goal here at the program I work with is we are abstinence-based. Patients should also be tested for HIV and AIDS, hepatitis B and C, TB, and other infectious diseases, as well as targeted risk reduction, counseling linking patients to treatment if necessary. when we do send people to residential treatment from here, most treatment centers require a complete and thorough physical before the patient is even considered to be placed into that program. And as part of self-care and wellness, it's a good idea for those that come into treatment, even on an outpatient basis, to go and get all of this testing done for themselves, just to make sure there isn't any other issues that needs to be addressed. Foundations for understanding includes the vocabulary, professional and ethical responsibilities, our values, morals, and perspectives. I believe over time, we all come to develop our own philosophies of how we work with people and how we treat them. There is a distinction between legal and ethical dilemmas, and then also reminding ourselves of the ethical values that we uphold in this profession. In regards to the scope of practice, there is the general counseling theories and treatment methods. Screening, there is screening, assessment, and diagnosis. And then we move on to the treatment planning and the case management, and on to the individual, group, and family counseling. Most of the work is done in groups because it is been shown to be effective for others to meet people similar to them that they can relate to and share their recovery journeys with. And we also need to provide patient, family, and community education in our work. So we also do a lot of outreach here when we're asked to do so. In regards to the distinction between the legal and the ethical dilemmas, we have the ethical dilemmas. Ethics are aspirational, concern professional practices and standards. So if you follow the NADAC standards, then you need to adhere to those. Here every year, as part of our CARF standards, we do have everyone review the NADAC addiction code of ethics, and they have to sign off on it that they have read it. It is, if not self-monitored, regulatory agencies step in. There is a safeguard for the autonomy of professional workers. So when we follow our ethics, it is also protecting us in the work that we do as professional counselors or helpers. The ethics are also dynamic and evolving. As I have worked with students that shared with me some recent changes in the last year about the code of ethics in regards to bartering. And I was like, no, that can't be. And they actually showed me that there was a change. So it is important to stay on top of any changes in regards to that. So that's what they mean by dynamic and evolving. Ethical could also be a matter of opinion and is not always a legal concern. On the legal side of this, it is determined by federal or state statutes. There are corrective measures in place, efforts to police the profession, litigious legal fears versus professional integrity, implemented if ethics are consistently violated. There is civil and criminal law, and enforcement sets precedents. Okay. Here we have the duty to warn. This is in regards to an infamous case of Tarsoff versus Regents at the University of California in 1976. In the Tarsoff decision, this relates to a court decision and has meant that if a person is in danger from a person with a mental health or behavioral health issue, they must be told, as well as the police. In the Tarsoff decision, the decision means that the therapist must tell the police if a patient is in danger to another person. So this establishes the duty to warn. And so whenever I meet patients for the first time, I always let them know that, everything you say here stays here, it's confidential, but The only exception is if you are danger to yourself or you want to hurt someone else, and that I am I have to report those situations so that I make that clear up front. Our ethical values are to be good, do good, and above all, do no harm to our clients that we are serving. Professional and ethical responsibilities, first of all, is to adhere to the established professional code of ethics. So the social workers has a code of ethics, the psychological association has a code of ethics, the counselors have a code of ethics, and then NADAC. So most agencies that are providing substance abuse services tend to follow the code of ethics from NADAC. We must also adhere to federal and state laws and agency regulations. So every state handles those differently, and it's important to become familiar with them. And you can now you can go online and look them up and research certain topics, and also be able to interpret and apply the information to the work that you do. These guidelines are here for you to follow, whether you are in social work, nursing, substance abuse, or mental health fields. More professional and ethical responsibilities. 4 would be to recognize the importance of individual differences. So this is when we want to look at the person's culture. We want to look at the gender. How do they identify? 5, utilizing a range of supervisory options. Your supervisor is a resource for you to use when faced with the ethical decision. Whether this is routine or a significant event, your supervisor or manager will likely have some experience and or precedents to assist you in making the right call. And I remember having been here for 20 years of being in situations where people like I said, there's a lot of trauma with our clients that need treatment services, and some of the stuff I heard, oftentimes I didn't know what to do. So I was so grateful to have experienced supervisors that were able to support me and walk me through some difficult situations that I had to address, which has also helped me with the work that I do now. I as the clinical director here, I often have my staff come to the door when they're dealing with those situations that they're not quite sure how they want to handle those. And so we'll sit here and we'll process it, and I'll guide them through that. So I'm always glad that they know that they need to come and get some help. Number 7 is continuing professional education. Every state has different requirements for continuing education, and you also need to be aware of those. As Steve said earlier, a lot of us are required to complete so many hours of ethics training. So I have 3 hours of ethics training every 2 years that I have to do. Good ethics training can provide foundational components for a new clinician entering the field, or a vital review for the experienced clinician, especially in matters surrounding mandatory reporting or child welfare. You must participate in ongoing supervision. You should be participating on a regular basis with your supervisor, who is helping you to excel and expand your knowledge and skills in working with people in the substance abuse field. So it's either weekly or bi-weekly supervision. It's very important in a clinical setting. Here in Montana, because I have some counselors in training, they're really specific on the certain types of supervision that they have. So it makes supervision here, I believe, a lot more work, because it's broken into all these topics that needs to be covered throughout their internship as they accumulate their hours towards their licensure. And I was like, wow, because I don't remember that being in place when I started. So now they're being more specific, and yes, you need supervision, but it must be in all these certain areas. So it's also work for the counselor in training. And it is also important to maintain one's own physical and mental health. This is self-care, and it is absolutely essential for your family, for your colleagues, and your patients who will benefit the most. It's like if you can't take care of yourself, you can't take care of other people. And it's good to be aware of your staff and how things are going. And I let them know if there's anything going on, you need to let me know. We have well, here in our office, we have sick leave. So sometimes maybe they need a mental health day just to clear their head and be ready to come back to work. So it's that self-care is number one. It is a real lot more emphasis is placed on the importance of that now than when I first entered this profession. And that is to prevent burnout, because it's a tough job that we do every day. This is the link to the NADAC Code of Ethics. So like I said, you might want to look at your state-specific Code of Ethics if you have them, and make sure that you're following them. Like I said, we review them annually here. The Code of Ethics examples for alcohol and drug counselors is responsibility to our patients, looking at dual relationships, and being in a tribal community. One of the things I like about being on a reservation that is not my own is it really eliminates a lot of the dual relationships that I would encounter when I was working on my own reservation, where I knew a lot of people, or maybe my relations came in and wanted me to be the person to serve them. So I would have to tell them, I'm sorry, I can't help you because you're my relative, and my code of ethics doesn't allow me to do that. We have to be mindful of our client confidentiality and our professional competence and integrity, our responsibility to students, employees, and our supervisees, having a responsibility to our profession, and financial arrangements, advertising, and legal and moral standards. So there are, when we talk about legal and moral standards, it's an example might be photocopying a book for a bunch of people and having the high moral code even when you're off the clock and you're not in your office. So again, we're looking at confidentiality here with our patients. Agency ethics. We have the disclosure of personal recovery, mandatory reporting, what are acceptable practices, and what are culturally appropriate practices. In the past, many substance abuse counselors have been in recovery themselves, and many are where I work now. And sometimes, they're really honest in seeking supervision when they need it. So for any of you that are out there that are in recovery, it's good to continue what you do to keep yourself sober and clean when you're working with your clients, and being able to get support when you need it yourself. So again, that comes down to self-care and maintaining one's their own recovery program. So I have people that come in, like I said, come into this field and they progress, they get interested and they want to do this work. So I'm always happy to help those, but I often have to remind myself, well, these persons are in recovery themselves. And so sometimes they have issues that they need some supervision for. In regards to ethical complaints, it is important that you know your state-specific procedures in filing and processing an ethical complaint. And because Steve is there in Iowa, there are all these different boards here. There's the social work, there's the nursing, There's a board of certification and the board of behavioral science. And so here in Wyoming, I often, well, I'm in Montana now, but in Wyoming, I was so familiar with accessing those, the code of ethics, that I was able to look things up readily. And here in Montana, I'm still searching and trying to find exactly what it is what I need. So sometimes I feel like I'm learning all over again. It's just states do things differently, and Montana does things a lot different than what I'm used to. Okay, now we're moving on to the patient rights. And that includes non-discrimination. We do not discriminate who needs our services. We uphold confidentiality, and we have a responsibility and also our competence in the work that we do. And we also have the informed consent. And in Wyoming, that is a part of your certification renewal. I'm still licensed in Wyoming, so I'm preparing for renewal this year. So they always want to review your professional disclosure, but it's also letting them know, like, this is what I know, this is my education, this is my certification. And if you have any problems with the work that I do, like my agency has an informed consent here, that they know they can report to someone if they're having a problem with the services that they're receiving from program or an individual for that matter. And when we talk about not discriminating, we are looking at the race, the age, and their gender. We want to avoid any personal issues and be knowledgeable about special accommodations. According to the American Disability Association, we may have someone who comes in that can't hear very well, can't see, they can't read, or are right, and sometimes they need special accommodations, and we have to do what we can to meet those. Again, under CARF standards, I actually have a form here that we sit down with the individual and we fill that out to make sure that we're doing what we can to meet those special accommodations. When I was off the reservation and working in maybe Cheyenne, Wyoming, or Rock Springs, Wyoming, I've, not only do I have all the years, I have experience in different places. And, I often had people that didn't speak any English. And so we would have to get translators in for them. So just being mindful of those people that need extra help. Looking at confidentiality, we also have our clients right at intake complete the consent of confidential information. A lot of our clients have to complete a release of information. And we just had somebody yesterday that, they wanted to remove their family. We don't want them to have any information, and they have that right to request that. And we also need to be mindful of their rights, again, in being in compliance with HIPAA and the 42 CFR. And there's the link here from SAMHSA on that. And then make appropriate provisions when necessary. Most of the court systems that I work with, we automatically sign a special release of information so that we can communicate with the court system on clients that are seeking services and receiving services here. Right now we have a referral system set up to where we're tracking them as they're referred to us, and we're letting them know when they come in. So they sign that. That's probably one of the first forms we have them sign, is that release of information to the court system. Confidentiality, we must adhere to federal and state confidentiality laws, know the exceptions to federal law, know how to respond to law enforcement requests for information, and present only necessary data. So in regards to the court systems, it's good to get to know the court system and ask them what it is they need specifically. I have had some courts who want the full report, and then I had some that just want to know what are you recommending for them. So it's good to get just the specific information. Some examples to exceptions would be medical emergencies, maybe a records audit, or a crime or assault to the person or property. So a lot of times we get calls here all the time here, and I'm always reminding my staff that we get moms that have kids in jail or girlfriends or wives, and instead of having that person take care of business for themselves, they jump in and start calling us. And some of these people are not very nice, but that's our day-to-day work here of handling these people that want to take charge of somebody and making sure they're getting treatment. And we have to let them know, hey, you know, if your son or daughter is an adult and they're over the age of 18, they need to contact us. They need to be the ones to call here because of confidentiality issues. We can't even tell you anything right now. More on HIPAA and 42 CFR, the general rule, there is the general rule, except under certain specified conditions. Both HIPAA and 42 CFR Part 2 laws prohibit the use and disclosure of records or other patient-related information. Responsibility to uphold policies and your management, assist others with knowledge acquisition, and report unethical behavior to the proper authorities. And when I was talking to Stephen earlier, before we were preparing for this, is looking at my my experience of having been in the field for 20 years. And I've encountered some situations where I've had to make these reports. One of them was a client. I was working in residential treatment at the time, and she was disclosing to me that her husband was also a counselor. And I had also noticed a lot of her making reference to him and things that he said about her treatment and her being in the program. And I asked her how long she'd been married and how she came to know this person that she was married to. And it came down to, she met this guy as she was his patient, and they got married, and none of that was known to anybody. And I was like, oh my gosh, this is unethical. It violates our code of ethics. And I know it does with the American Counseling Association of, we're not to have intimate relationships with our patients. And this was one of the examples of this guy had violated all of that. And, you know, I had a supervisor then because I felt like she kept reminding us of things, and I'm sure it was talking to her husband that was a counselor at the time. So that was one of those sticky situations that I've had to handle. So we have to, you know, be watching the people and the work that they do, and being able to make that call when you know it's necessary, because you know it's important for the safety and well-being of the people that we serve. Again, looking at our competence, ongoing education, I always tell people I'm one of those goal-oriented people of, like, you know, what's the latest treatment modalities out there, you know, what it is that I want to learn. So as you encounter things, it's often good to have a professional development plan in place at work, so that each year you're evaluated on your competence and looking to build your skills of, you know, what other trainings would you like to have. It is also important to have boundaries and limitations. And, you know, we had every morning we have a meeting here before we start our day, and our discussion this morning was on boundaries of, you know, we have a client who was in school with a couple of my counselors at one time, and they said they felt like they wanted to help her more than they know they should. So they were like, I had to remind myself I have to have boundaries, and she's not my friend, and I'm her counselor now, and I'm helping her. So also looking at, being on the reservation, like I said, my counselors know this person. And so it is hard sometimes because you want to almost cross that line, but it's good to remind yourself, these are some things that I can't do. Having that professional competence and integrity. And that means knowing what, there may be some things you're just not comfortable dealing with, and who can in your office. So we need to know, who do we go to when we have, certain issues, and how do we handle those? So not taking on something that you're not able to do. In regards to our ethical principles, the first one here is autonomy, allowing an individual the freedom of choice and action. It addresses the concept of independence. The essence of this principle is allowing an individual the freedom of choice and action. It addresses the responsibility of the counselor to encourage patients when appropriate, to make their own decisions, and to act on their own values. These are two important considerations in encouraging patients to be autonomous. The first is helping the patient to understand how their decisions and their values may or may not be received within the context of the society in which they live, and how they may impinge upon the rights of others. The second consideration is related to the patient's ability to make sound and rational decisions. Persons not capable of making confident choices, such as children and some individuals with mental handicaps, should not be allowed to act on decisions that could harm themselves or others. The next one is non-maleficence, not causing harm to others, above all, do no harm. This concept is not causing harm to others. It's often explained as just what I said, do no harm. This principle is considered by some to be one of the most critical of all the principles, even though theoretically they are all of equal importance. This principle reflects both the idea of not inflicting intentional harm and not engaging in actions that risk harming others. Beneficence, the counselor's responsibility to contribute to the welfare of the patient, to do good. Simply stated, it means to do good, to be proactive, and to prevent harm when possible. The next one is justice, treating equals equally and unequals unequally, but in proportion to their relevant differences. Does not mean treating individuals all the same. So it's treating them, just knowing that there are differences in how they're going to work with those appropriately. And fidelity is loyalty, faithfulness, and honoring commitments. Patients must be able to trust the counselor. And when you're working with Native Americans, this is a big, huge one in my perspective, because, we've had that trust violated since the beginning of time for us here as natives, of being lied to and, treaties being broken and violated. So that is a big one of being able to trust. So this involves, honoring commitments. If you say you're going to do something for someone, then you need to do it. Okay, we'll go on to the next one, looking at boundary setting. Again, I discussed this just a little bit about that issue we discussed in my morning meeting this morning with my own staff. We don't want to do any harm, the non-maleficence, and looking at transference from the patient. This is from the patient to the counselor. Sometimes they may, trigger something. And also looking at the counter transference of the counselor to the patient. So we also need to be mindful of ourselves if there are any issues that we need to address within our own selves. And sometimes, coming from, I often share with people, what brings me to this field of work is having had an alcoholic parent, and wanting to make a difference. And, what brings me to this work also, is wanting to do my life differently. But then, there are some things that in your line of work that will bring up certain things, and you need to be able to address those. Boundary issues, there's those dual relationships, and that's kind of what my staff were talking about this morning with the client that they're providing services to. Of this is someone that they know well, and having to remind themselves that I'm not their friend. I'm here as a professional counselor right now to help this person. And in regards to sexual and affectionate feelings versus behaviors. So when we talk about ethics, I've seen people who have had to who have been reported and what they've had to go through to try to regain their licensure, and some people never regaining it back at all. And those are following our ethical guidelines. And in the Wyoming professional disclosure statement that I have to renew every 2 years, I mean, I have that in bold print on mine to, to inform my clients, that having relationships with our clients is unethical and it's never going to happen. And then the remuneration, also known as bartering for services or quid pro quo. And this is the one that has recently, in the last couple of years, in the American Counseling Association Code of Ethics, is actually changed this specific standard there. So if you're in the counseling profession, you might want to look that one up. But that would be, I'll provide counseling services if, you come mow my yard or whatever, work in exchange for it. And I have a friend who's an attorney, and he gets all kinds of stuff for his work because they can't pay, and he's able to do so. So I was like, wow, I didn't know you could do that, but he does apply, he's in a different profession than we are. We have the mandatory reporting. Again, the duty to warn based on the Tarzov case that is specific to the threat to the self or others. Also looking at child abuse and the sexual misconduct of a therapist. And when I worked in residential treatment, I did encounter some situations where, again, supervision was key to that. And I had to make those reports. And it's often handled very well. I don't know if any of you ever watch Dr. Phil at all. And I see him bring people on his show, and it's clearly evident. And he's like, you could be in so much trouble because I see this and this and this. I mean, it's apparent to the whole country, whoever's watching. But then he points out, we have a chance to help you, and we'd like to help you. So I was like, wow, it's for me, I'm one of those people that likes to watch Dr. Phil. So I see those things clearly, and you'll encounter those as you do this work, and you need to be prepared to respond to those situations. And that's when you need to lean on your supervisors who have experience in handling those situations. Using supervision, test concepts, rationale, and practices. Transform recommendations to action. So whatever recommendations you're given by your supervisor on how to handle a situation, you need to be able to apply those. And then we also look at the administrative, clinical, and evaluative supervision. So here, CARF is what guides this agency. And so my staff have to do regular supervision that covers certain areas that each of our staff needs to cover when they go through supervision, always being mindful of ethical situations that could arise. So you need to be able to document situations discussed. So when you do supervision, you should have a supervision form that is being completed that documents that session and what was discussed. So, one might be how many patients do they have? Are they following procedures? Helping your staff learn, a broader scope of practice. Sometimes we know of books that we can give to our staff to read that will help them. Or maybe as supervisors, we realize these guys just need some training. Because I have counselor trainees, I'm real fortunate to have people that can do training for me. So I just call up the people that I know that specialize in this area that I can send my people to so that they can get training. And so next week, my staff will be trained on ASAM criteria, because we have some new people here that aren't real knowledgeable. And like I said, every state does things differently. So allowing them to enter this profession here in Montana is a lot different from Wyoming. So I often encounter things that my staff need training. So even as a supervisor, I need to know, I have a responsibility to make sure my staff know these things and that it's documented. Okay, Steve, put some
Yes.
questions in here for
Well,
us.
and I thought before we come into some of the quiz questions, just to kind of get your juices flowing, the audience that is, let's take just a moment to open the floor up for any comments, questions, thoughts about this past hour and the information that's been shared. Anybody have any? I was watching the chat. There wasn't a lot. I think everybody was listening so intently that. Does anybody have any comments or thoughts or questions before we try some quiz questions? I think it's unethical not to have any questions about ethics. How many of you, while listening to this, felt like, gosh, this is stuff I deal with on a daily basis in my practice? A lot of people. I see Heather shaking her head. Yes. Oh, here we have Luis. You can go ahead and unmute, Luis, if you have a question.
Oh, no, you just asked that question and I was raising my hand to say yes.
Oh, yes, you were agreeing. Thank you. I appreciate that. As any chance I get to use the hand raising feature, I always jump on it. So you're right. We're on the same page there. Well, unless, and we can stop at any point too. There's about 10 quiz questions. And I know Avis and I were talking before we came on. We're not going to really do a polling question. I think if we had more time, we might break into small groups and have each group kind of go over some of these. These are really based on quiz questions that we've utilized in some of our other trainings. And so think of it as you're trying to find the best answer. There may be some that also would be the answer, but would be the best, highest ground ethical solution to some of these questions. For some, there's only one answer, but others you might think there's more than one. So should we just, Avis, why don't we just go ahead, and if you want to just read the question, and then we'll open the floor up. And if you guys want to use the chat to maybe punch in an answer, we can kind of, and then if we get stuck somewhere, we can stop and have a discussion too. If one of these quiz questions kind of sparks a thought or an interest, we can stop and talk a little bit. So there's the intro to the quiz questions.
Okay, a treatment counselor is contacted by a patient's medical doctor who is interested in obtaining information about the patient's progress. The patient has given permission to release information. The counselor should A, give the doctor a copy of the patient's file, B, give the doctor only the information that is requested, C, refuse to release the information due to confidentiality requirements, D, set up a meeting with the patient and the doctor, E, ask the patient to give the information directly to the doctor.
We're getting quite a few answers here. Audience, is this your final answer? We have Heather asking, does the question reference the updates and changes with 42 CFR? No, it probably does not. I know there were some changes that were implemented about what could be released and what could not. We're basing this simply on the notion that there is an ROI in place, and how would you handle that? That's a great question. The updates to 42 CFR that came out, gosh, what was it? Two summers ago. We could spend some time talking about those. They weren't extensive, but they were certainly noteworthy. The correct answer is B. Yes, you guys nailed that one. Only release the information that's requested. Okay.
Okay. Question number 2. A situation that would not justify a breach of confidentiality would be A, a patient has threatened to kill his wife. B, a patient has threatened suicide. A patient has sold drugs in order to support his substance use disorder. D, a patient admitted to committing child abuse. E, a court order stipulates that a patient's records should be released to the police.
Okay. Yeah, you guys are onto this one too. So what the patient selling drugs, it's not a reason to breach confidentiality. It's just simply not, it would not justify a breach or a compromising their confidentiality. So yeah, you guys are right on. Well done.
Go on to number 3. An old friend of a clinician who has his own private practice suffers from a drug abuse problem. Since he wants to help his friend, the clinician agrees to counsel his friend twice a week without charging for the sessions. The arrangement is A, ethical, if the patient meets the criteria for non-payment on a sliding fee scale. B, neither ethical nor unethical. NADAC ethical guidelines do not address situations as these. C, ethical. The clinician is providing services within guidelines for private practice. D, unethical. NADAC ethical guidelines prohibit dual relationships such as the one described here. E, unethical. NADAC ethical guidelines prohibit pro bono sessions. What is the answer here?
Yes, we've got a lot of answers coming in, and yes, D is the correct answer. This addresses a dual relationship ethical issue. Okay.
Number 4, after a clinician has written a case custody on one of her patients and submitted it to a professional journal for a case study, sorry, I said custody, didn't I? Has written a case study on one of her patients and submitted it to a professional journal for publication. The clinician supervisor, who is a well-known psychiatrist specializing in chemical dependent treatment, edits the document and writes 2 paragraphs. When the clinician lists the supervisor as the first author and himself as the second, the clinician has acted A, ethically, as long as the supervisor's last name alphabetically precedes the clinician's last name. B, neither ethically nor unethically, the ethical standards do not address trivial issues such as this. C, ethically, by properly crediting his supervisor's contribution. D, unethically, the clinician should not have listed himself as the author of the article. E, unethically, the clinician should have listed himself as the first author. What is the correct answer here?
This one's a little trickier, but the correct answer is E. The author should have, the clinician should have listed him or herself as the first author.
Okay. Number 5. A patient who has been in therapy for 6 months informs her counselor that she is going to commit suicide. She claims that she has a gun at home and will use it that evening. The counselor's best course of action would be to A, keep the secret, B, initiate hospitalization of the patient, C, do an immediate evaluation, D, make a new suicide contract, E, call an emergency assessment team.
Let's see what we have coming in on the chat here. Yeah, this is an interesting one too. The correct answer here is B. B is in boy. You would initiate hospitalization. Some of the other components, aside from A, might be something that would be done concurrently or subsequently, but arranging for hospitalization would be ethically your responsibility. Okay.
Okay. Number 6, your patient who was just raped knows who attacked her, but doesn't want to press charges. She says a trial would be too disruptive to her family. She lives in a small town. Her children are in junior high, and her husband has a high-profile position in the town's largest company. What is your first responsibility? A, to call the authorities. B, to confirm that she has received medical attention, and if not, have her go to the doctor immediately. C, to treat her and keep everything confidential. D, to speak to her husband about their social responsibility. And E, to treat her but assert privilege.
Okay, we're getting some answers in. So again, we're looking for the best answer here, and the correct answer here is B.
Yep, it is. They have a process that they go through. On to number 7. A drug counselor is contacted by a patient's medical doctor. We over covered this one.
Oh, did we?
Yeah.
I thought this was maybe this was a different one. I thought it was a little different, but yep. Maybe we're just going back. This is just to see if we remember. Yes, I'll make a note to number 7 is a duplicate.
Just pull it out.
Yep, I'm gonna delete it from the deck here, or on my end anyway. Sorry about that. Well, I'll find a better question set.
Yeah, that would be great. That would be great.
All right, question number
8.
8. Well, really 7, but we'll call it 8.
Okay. The goal of confidentiality is A, protecting the public, B, protecting the counselor, C, protecting the profession, D, protecting the process, and E, protecting the patient.
You guys know this one. Yes, good. Yep, correct answer is E here. Goal of confidentiality is to protect the patient. Okay, a couple more.
The goal of ethics is A, protecting the public, B, protecting the counselor, C, protecting the profession, D, protecting the process, and E, protecting the patient.
Yes, you guys have this one too. Ethics is to protect the profession. Well done.
Okay, one more. Which of the following presents the greatest risk to confidentiality?
The
A,
greatest risk. That's the key.
greatest,
Avis, this came up.
underlined.
Avis and I taught a course in Billings late last year, and this question we had some discussions about with the group. The greatest. Which of
Okay.
the following presents the greatest risk to confidentiality?
A locked file cabinet in view of waiting patients. B, a computer desk in a counselor's office. C, a large family in a therapy session together. D, making referrals. And E, an individual counseling session located next to the waiting area. Oh, the greatest. Okay.
And the greatest risk here. What of these scenarios, which one do you have the least control over? This is a tricky one. I missed this when I first read this question. The correct answer, according to our source, is C. The greatest risk is doing having a large family in a therapy session together. These other ones, yes, they're all potential risks, but this is deemed to be of the choices, this is deemed to be the largest risk or the greatest risk. I know, I missed it too. If anyone was befuddled by that one, we're still looking into to make sure that this is the best fit. I've been in clinics where you could hear through the door or through the wall a session going on. So I mean, those are always issues. Making referrals are certainly there's a risk there, because if you don't have the proper ROI, or you have a clinician that's not trained or understanding the process, certainly having a computer on a desk, if there's not a lock feature or a safety measure in place, and then obviously a file cabinet that's locked could still be accessed. So, well, those are the quiz questions minus the duplicate. Avis, any closing thoughts or anything to consider? I think there were some reference pages in the closing slides,
There's
or just a summary.
just a summary of everything that we covered here today. The key points to remember are be good, do good, and above all, do no harm. To distinguish among ethics, morals, and legalities. Patients' rights are always foremost. Your ethics can greatly impact the quality of patient care and the image of the profession. And boundary issues start with small, innocent transgressions. That is just a summary of everything that we covered here today. Does anybody have any questions that they might want to ask? We have a
There's
few
some
minutes.
reference pages that you'll have access to this slide deck. You'll just have to. I think what I'll do maybe is send over the edited version with that extra quiz question taken out.
Okay.
But you'll get a copy of these slides, everyone. Let's open the floor. We have a few minutes. If there are any closing thoughts or questions, we can certainly take those. Again, I
Want me
want
to
to
stop sharing here.
Yeah, we can pull that down. Yeah. I want to thank everyone again for your attentiveness today and your participation in today's webinar. You're welcome, Kevin. Always good to see you. And we don't have any closing thoughts or comments for Avis. We can go ahead and conclude today's webinar. Last chance for any questions for Avis. Getting a lot of thank yous, Avis, in the chat here. Well, great. So next month we will broadcast again. I'm going to, if you want to, you're certainly welcome to complete the survey here before we sign off, or you can just wait and try that survey once you get the follow-up email. And you can also request the CEUs, as I mentioned earlier. Let's see, Avis, next month, I'm going to look at my whiteboard here. I'm going to cheat a little bit. Let's see. It looks like next month we're going to be doing treatment knowledge. And that will be the first Wednesday of March. That I'm calendar compromised.
March 2nd.
Yes, I guess it'll be the same dates as February. Which, by the way, today I was doing my journal this morning and I wrote 2-2-2-2.
Mhm.
But that won't happen again for another 100 years. So
Yeah.
that was interesting. Thanks again, everyone. We do appreciate your patronage and attendance, and we'll see you next month for discussion on treatment knowledge as it relates to substance abuse or substance abuse skills training with this webinar. So thank you, everyone. Until then, stay safe, stay connected, and stay healthy, and we'll see you again. Bye.